Hi, I'm Fran Jenkins with North Island Now. Welcome to the Conversation Series. Today I want to have a conversation about healthcare in my local community, but also around the province as well. There are so many issues surrounding hospitals, healthcare, doctors, island health. Today I want to sort through some of the things that we hear about, that we see, that we experience when we're in need of healthcare ourselves or a family member. Today I'm joined by Dr. Prean Armogam, who has a private clinic, the Port McNeill Medical Collaborative. And I'm also joined by Dr. Alex Nataros, who has the North Island Community Health Center. Welcome. Thank you. We've had some pre-discussion, and I know you both have a lot to say. Prean, can I start with you? And is it okay if I call you Prean and Alex? Because that's what we call each other. So full disclosure, Prean, you've been my family physician for 20 years, so thank you for keeping me going. But I'd like to know, how long have you been involved in healthcare up on the North Island?
You know, when you work in rural areas, it's not uncommon to get thrown in straight away. So I would say nearly the 20 years that I've been here. It was early. It was 2 days earlier for people ahead of me, like Granger Avery. And so right from the beginning, we've got thrown into it to try and make system change, make improvements, respond to an ailing health system.
And to me, as a physician who is such a key part of any community, the healthcare aspect, it should be part of your job to try and to make things better. You know what the conditions are where you are, and you would have ideas for how to improve them.
You know, advocacy is part of sort of our competency things as our roles as physicians, and so the short answer, yes, we need to advocate for ourselves, for patients, ultimately for better care wherever we land, wherever we find ourselves. So it's really part of our role to do that in whatever system we find ourselves, or administrative structure, or any kind of environment that we feel can improve our patient care.
And Alex, you're relatively new up here. How long have you been here?
Yeah, so I rolled in to Alert Bay first in July 2022 on a locum. I'd heard about North Island challenges, closures in Alert Bay, closures especially in Port Hardy, in my years working in the Comox Valley, and I decided, you know, things had gotten quite busy in the Comox Valley through COVID. I wanted a change of pace, and I wanted to work similar to where I was trained, in a more rural setting. And so I bought a patch of land in August 2022, and since have lived here on the North Island in Port Hardy.
And you have created, I kind of think, the ideal format for a healthcare center, because you don't only have physicians, you have a chiropractor, you have, what else? Who else have you got on staff?
Totally. We're meeting here today at the North Island Community Health Center, and our mission is to provide health and wellness care to the North Island population. And what I experienced when I was in the Comox Valley is, dime a dozen physiotherapists, massage therapists, chiropractors. Not hard to get in to see an allied health provider. When I started working here, it was like, well, there might be a physio that you wait 2 or 3 months with Island Health to see, but to actually have access to care was uncommon. And yet we have so much illness up here in terms of, blue collar population, fishing, logging, mining,
Hardworking.
Elderly population, hardworking, significant social determinants of health and illness. And so from my perspective, it was important to create a new model, because we weren't meeting the needs of the population, at least from what I saw working, 6 months in an island health system. And so we've started, and we've got, 4 medical doctors here, a chiropractor, 2 physiotherapists, a registered massage therapist, and a brace and orthotics fitter, a foot care nurse, and a counselor.
I just think that's so clever to, and so fortunate for our community to have that kind of broad level of care available. But it's not only that, like, your physiotherapist does yoga.
Totally.
Here.
In this room that we're in, we do group medical visits, and I'll do sessions on arthritis with our physiotherapist in a group of 12 to 15 people, and they learn from how a doctor works with a physio, from how a physio learns from their patient, or a doctor learns, this medication works better than this medication. We learn together in community. So, I think we can do better by learning and healing in community than we can by trying to heal in bureaucracy.
Something that you do that I think, I just love the idea of it, walk with the doc. I just think, like, it's so simple. And do you get many people out?
Yeah, we do pretty well. It's like everything, you got to hustle, right? You got to put posters up, you got to make Facebook pages and events and otherwise. But, we get 15, 20 people out, which for a small North Island community is pretty good, right? And we walk, for all those people we get, there will be another 15, 20, 30 who said they'd come. Or, you know what I mean? Like it's an effort. But even just the awareness that you can connect with your doctor outside of the exam room, this is trying to do healthcare differently. And, I'm standing on the shoulders of giants like Dr. Prean Armogam and Dr. Granger Avery, who've led the push for better healthcare here on the North Island for decades.
So I'm gonna make a point here. Can you tell me how many patients you have on your roster?
I've got about 1,800 currently. Here at the North Island Community Health Center, we have patients who've moved to Victoria or Powell River or the interior. And so our overall number of actively rostered patients is about 5,000.
For the whole clinic?
For the whole health center, yeah.
Okay. Prean, the point I kind of want to make is, why don't you do this? Can you tell me how your patient load is?
My attachment at the moment sits at about 2,500.
2,500.
You have to recall, though, that we were the clinic of 5,500 people before the clinics were split in Port McNeill for whatever reason, and we still do a lot of outreach. What Alex is really discussing or framing is this whole idea of the patient-centered home, of primary care networks, of things that the province has endorsed over years, over the last couple of decades. But Alex is actually doing it. So I'm in awe of the achievements Alex has made, especially in the short time that he's been here, plus the challenges that he has faced on a few levels. Why don't I do it? It's I think availability, space for one.
Well, and I make that point with love.
Yeah, of course.
Because I know how busy you are. I know how many patients you have. I know how many outreach places you serve. And there is just no way. And you have had to fight and work so hard for Port McNeill and for the Port McNeill Hospital that there's just no way in your set of circumstances that's something that you could take on.
I also, just to, sorry to interrupt, but we're collaborating as we are here, and it's a great discussion, but we're also approaching things differently. Prean's working within the system to change the system, which is very admirable. I have walked away from the system. I resigned my privileges and have created something new. And so both are effective approaches, right? And I think that's what's so neat about this dialogue today.
I think it's important, both aspects of it. You have been struggling and trying to fight the system for a very long time.
We have, and it gets sidetracked on who you're fighting and what you're fighting, and ultimately we're trying to advocate for patients, for our fellow providers. On the clinic front, as you know, I think the same. So we have foot care people visiting through the clinic. We have a visiting plastic surgeon. We try to grow that, because this whole concept of making sure that the specialists get to see it, it's really a space issue, and it's around sort of support for what that looks like. As you know, there's another clinic in Port McNeill, which is a health authority funded clinic, and it was historically the kind of clinic we ran originally with a larger physician group. It's purely a matter of space and costing as to why we're not able to do it. Alex is ahead of the game in terms of what he's doing at the moment.
Sorry, I'm just going to clarify that you also have in your space, you have a physiotherapist.
Yes.
And you have a kinesiologist.
Yes.
So you do have, it's not just you, there are other services certainly available there as well.
Absolutely, patients have access.
It's very similar what we're doing, and part of what we've built here is guided by what we learned from Dr. Armogam.
Awesome.
And so the other thing is, I was very lucky, 2.5 years ago when we moved forward with building the North Island Community Health Center, is I was approached by Dr. Howie Lee, who, like Dr. Armogam, has put in nearly 2 decades of time on the North Island. And Dr. Lee said to me, hey, Alex, how would you like to, be done with Island Health and start our own thing? So, I again am standing on the shoulders of giants here. This isn't just, my doing.
Our communities are both fortunate to have both of you. One of the huge issues up here is the closure of the Port Hardy Hospital at night, evenings and night, with all emergency cases coming to Port McNeill. Would you say that there's a significant amount of traffic coming from Port Hardy to Port McNeill for ER care?
So we fondly call it the gates of hell open at 5 o'clock at Port McNeill Hospital, where all the emerge rooms, any other acute care defaults to Port McNeill. The ambulance start coming in streams. They're just dropping off people, gone out for the next call. To answer your question, there's a large traffic come 5 o'clock. Everything. So Port Alice doesn't have an emergency room, but folks from Port Alice, from Alert Bay, from Port Hardy, a lot of people from Port Hardy. It's a bigger population. It's a population that really needs more care. A lot of whom come to Port McNeill. So every day there's this influx come 5 o'clock. The days in Port McNeill can be variable, depending on the local population. Also depending, strangely, that these other communities we mentioned also filter in through the day into Port McNeill Hospital. But come 5 o'clock, it's the only hospital that's open 24 hours. So there is significant traffic at night, particularly social determinant things that could be mitigated in the community, but we see them. And of course, acute issues, people who are really sick.
Mm-hmm. And can you tell me how many additional staff are supplied to the hospital to help cover this opening of the gates of hell?
As far as I'm aware, and maybe people who do the staffing things can better comment on that, but there are meant to be 2 or 3 emergency staff, nursing staff. There's only one physician on call for 24 hours in Port McNeill. So it depends on the luck of the draw through the day, depending on how busy you are. But come nighttime, you can fairly predictable that you're going to be busy, and you're not going to get much sleep. As far as physician staff, there just remains the one physician. As far as nursing staff, there's usually 2 or 3, but the struggle is getting emergency trained nurses to function in an emergency room or designated emergency room. There are some support staff in the sense that there are care aides, etc. on the floor. There are LPNs on the floor who are helping inpatients. Sometimes the LPNs cross cover to the emergency room. Diagnostics are available to a certain time. So X-ray, for example, is available 24 hours. But we're encouraged not to call them unless it changes our management for fear of that the X-ray tech will not be available the next day. The similar thing holds true for the labs. We cannot call labs in for certain things like abdominal labs, or if somebody presents with an acute abdomen, for example, or other issues like it. There are ISTAT or POCHI testing, which the nurses can do, which is fraught with its own sort of issues. So the lab, we also cannot call lab in the middle of the night because for fear of people losing their outpatient lab spots the next day because the lab tech may call in sick. So it's a finite resource in the sense that the nursing staff, they're mostly band-aided, and I know the guys who try to fill the shifts, the staffing folks who try to do this, they try their best to fill it, but often we don't have any emergency trained nurses, or if we do, we have one and they too, but thankfully they replenish themselves every 12 hours.
So a physician on call at the hospital 24 hours.
Yes.
You would probably work your clinic day.
Historically, we were able to do that because the volume wasn't particularly large, but now it's almost impossible to run a clinic day and an emergency.
And so you are just on call at Emerg.
Yes.
24 hours.
Thankfully, we're not on site on call at the moment. This is all in the process of change at the moment, so we can be at home and they call us and we deal with whatever we need to, and then we go back home and come back, sort of thing. So we don't have to physically stay with the current structure, although that's in the process of changing.
And then would you have to work the following day?
Almost certainly. So these are things. So yes, we work the following day. Clinics, outreach clinics, as you talked about. I go to a lot of the other folks who do call also work in other clinics. They have outpatients in the community that they need to see, and then locums, for example, who for whatever reason they want to work just in the Emerge. They don't have clinics. They don't have established patient panels to continue to service. They generally do not see patients the next day, or some people want to do only the hospital work and the emergency work. So that one physician stretching over 24 hours still has to work the next day.
So that's a really long shift for someone who holds my very life in your hands, your very tired hands.
It is, and there have been many letters written to the ministry on this particular point about the one site having to do this burden, and only one group of providers having to do this.
And a small group.
And
of
a very
physician
small,
group.
very small.
Very small group
Yeah.
trying to cover
Yeah.
24/7
Correct.
ER in McNeil.
So much so that the physicians who actually work in McNeil will preferentially pick up shifts in Port Hardy or Alert Bay, or dare I say Port Alice, based on the fact that they're remunerated the same to provide 10 hours of work versus the 24 hours that some of us are still doing in Port McNeil.
And they get to go home at 5 o'clock and be done for the day.
And so these are other issues that it creates discord and dissension amongst the physician group, and it's fairly divisive, which is not helpful for a
No.
larger physician.
There's no time or room for that. So I did a little digging, and I discovered that the Port Hardy Hospital and the Alert Bay Hospital were shut down overnight as of January 2023. I also discovered that as of July 2023, Central Saanich Hospital was closed overnight. I would have thought there were more. There's been such outrage. But that only closes the ones that are officially, 5 till 7 closed. There have been many temporary or intermittent closures along the way. Since 2023, there have been 29 of BC's 77 ERs closed in some way or form temporarily. In 2025 alone, there were 250 ER closures, mostly affecting rural communities. Why do you think they're picking on rural communities?
Why is the prevailing government picking on rural communities? In part because the power isn't in the rural communities. The power lies in the cities, and the votes, at least for the prevailing government, to come from the cities. So it's easier to ignore rural communities. And we see this across Canada. This is not limited to British Columbia.
Of course, yeah.
But I think the mismanagement is particularly acute in British Columbia. And as I'd said, I moved to Port Hardy because I had spent a year, 2 years hearing on CBC radio every morning the announcement that Port Hardy Emerg is closed again. So it was permanently closed as of January 2023, but there had been rolling closures for many, many months. So, it's not just the past 31 months, it's 31 plus many months prior of uncertainty. And this uncertainty is stressful on the population, right? And you think of the unknowns of, all our, older patients who live with the possibility of having a stroke or a heart attack or a fall, and what would happen if it's after 5 p.m. Where do they go? Who do they call? What do they do? Yes, on paper, it's 43 or however many kilometers down the road, but it's actually a much bigger deal than that. It's getting the ambulance, it's getting the transfer, it's getting, beyond the pileup of the gates of hell that has formed in Port McNeil. So, I think there's people like Paul Adams with the BC Rural Health Network that have done a really good job of examining why our rural communities are not being listened to. I think the creation of the health authorities in the 1990s is part of that, where the power structure for the communities no longer comes from the rural communities. It no longer comes from our rural hospitals. It's in Victoria, in the Island Health, offices. It's in Kelowna, in the Interior Health offices, right? It's in Prince George, in the Northern Health offices. It's not in the rural communities. So, it's one thing for us to, when an election comes, say rural matters, but 364 other days of the year, we actually have to behave like it matters. So, when we talk about rural and why it matters and where the focus of power for our hospitals comes from, that shifted an awful lot in the 1990s. And one of my mentors, who we've talked about already today, Dr. Granger Avery, who's a pioneer of rural medicine in Canada, an Order of Canada recipient, and really pioneered a lot of the organizations that run rural healthcare in Canada. He told me, just at Gus's over drinks in Port McNeil, he told me about the creation of the health authorities in the 1990s when he was the president of the BC Medical Association, and how they were created by the Ministry of Health as a political shield. And so they created distance between the Ministry of Health and the communities, so that the communities couldn't hold their community organizations and their hospitals accountable. So no longer was it a matter of rolling into the Port Hardy Hospital and saying, I wasn't happy with my care. You had to go all the way to Victoria, to Island Health, to the Ministry of Health. And that just creates, further barriers to accountability, to the point now where there's no accountability.
Well, and that was a point that I had running in my head too. Given the two entities, the government, the Ministry of Health and Island Health, where does accountability lie? Ministry can say, oh, no, that's an Island Health thing. Island Health can say, oh, no, that's a ministry thing. And God help you if you ever want to find the bottom line, the answer to that.
Totally. Who are the
total
comedians?
deniability on both sides.
Who are the comedians? You guys would know who's on first, who's on second, right?
Yeah.
So exactly. There's no accountability, and it's a convenient tool. It's a shield.
And I think you talked about the health authorities kind of transferring the power to offices in Victoria, where people are making decisions based on wildly varying areas of geography, of populations, and not having a clear understanding of, well, why can't the people from Wickenow come to Port Hardy Hospital? Well, because, it's a 40-minute airplane ride. That they're looking at numbers on paper, on data spreadsheets. It looks lovely. Oh yeah, we'll just do this and this, without any understanding of the reality of the situation immediately locally.
I agree. And it's true that when you've seen one rural community, you've seen one rural community. They're all different. And what irks me the most is the decision makers rely on information, maybe data, but that does not appear to be the strong point. Data and objective outcome measures don't be the strong point on decision making. The feedback chain. So the federal government is not responsible for healthcare. The federal government defaulted to the provincial government. The provincial government, as in the premier, appoints a health minister, and there's this back and forth between the health minister, the deniability between the health authority, who's waiting for direction from the health ministry, but the health ministry is saying, it's up to the health authorities to make this decision. So despite that the decisions firmly sit with the health ministry in BC, and ultimately as a representative of the premier of the province, and there's no one else where he responds to apart from the Governor General. But the public need to understand that as people on the ground, we've been advocating for change, for safety. The critical safety things that have happened for patients over the last few years have been astounding, but yet there is no momentum, no direction on change. So we talk about inverse care. There's been a lot of funding and talk about people on the front line being ignored. There have been multiple reports. There have been multiple actual documents produced about what level of care looks like, how repurposing resources looks like, all of which gets fed to upper layers of management, as in executive directors, to the board, who ultimately, all under the health authority, who feed into the health ministry, who make these decisions. Yet the decisions and the points that are raised by the frontline staff who are living it every day, who make it really tangible, who are at the interface of patient care, get ignored. So people who make a lot of decisions, big decisions, minimizing or not recognizing input from frontline staff, silencing frontline staff to some extent, all to what benefit? I thought we were all in the same business of patient care, of good quality, safe patient care, and we're not having that. So for me, the difficulty I have is there's so many safety pieces that are missing, and the public is not aware, or they provided messaging that's ambiguous or does not actually frame the reality of what's going on. And I think there is an obligation in the interest of for the public interest. There needs to be disclosure on the safety risks that we're all facing at the moment as frontline staff. But management level and decision maker level, is not recognizing that. There's so much more management and decision makers at a level. So regulatory people, administrative people. There's not as many frontline folks doing the work. Firstly, secondly, nobody's listening to what they're actually reporting and saying. There is some mechanism to actually not hear what they're saying, and it just seems backwards to me.
Well, for myself as just, average Joe citizen, and because I know you and I hear about some of these risks, it is scary, and the public has a right to know. That is our health care.
Well, that's where the physician comes in, right? Doctors are the only individuals in the healthcare system that take responsibility and are held responsible for patient care. And yet that means we're incredibly vulnerable for the reasons that Dr. Armogam has said, right? And so it's very tricky, and it's easy for the health authorities to single us out as physicians and scapegoat us for systemic problems. And it leaves us very vulnerable. And yet it means that what we're doing here today as physicians, advocating for patient care, advocating for our rural communities, is so critically important. And advocacy is one of the key tenets as medical doctors.
The word impact keeps popping into my mind with what you've both been saying. So the impact for you as physicians, having a critically ill patient that can't get what they need in a timely manner, the impact on you is huge. The impact on the patient is huge. But if you build enough levels between the physicians and the patients and the Island Health and the blah, 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 well, all of a sudden, oh no, look, there was only 17 mortalities up in that area this year. That's pretty good, okay. There's no impact left. The impact is all left right here in our communities. And there's no one above the line that is feeling that impact. It's just another report to them.
If it gets reported at all.
Mm-hmm. And that's one of the big challenges, is access to information. And so, this isn't just a symptom of the current government provincially. This is generally governments have been suppressing information and access to information, making it more expensive, more difficult to get this data that tells the story about what's happening in our communities.
I tried to get information on how much the government was saving by having the Port Hardy Hospital closed for the hours that it's closed. And there is no data available. Like, why is that?
Let alone how much it's costing to pay the ambulances, the drivers, the paramedics, the helicopters, to do the transfers, let alone the social cost of all these patients.
Well, that's it. Like, the cost isn't just monetary.
No.
The cost is in lives.
Let alone how do you manage, my little old lady in her 80s who doesn't really drive, doesn't want to call an ambulance, and can't make it to McNeil, and she comes in scared, shaking with anxiety every time she sees me because something might happen. How do you measure what might happen?
As an aging population, and as a member of that aging population, that is scary as hell. If I have a stroke tomorrow, am I going to get the medical treatment that I need fast enough to make a difference? And to know that what we have here is what we have, and we're going to go into that in a little bit, but that beyond here, the next level of care is a 2-hour drive away. That is really scary when you're thinking about a stroke or you're thinking about a heart attack, because that can be the difference between life and death. I want to talk about the definition of an emergency room. They had that information available. So I'm going to ask you each for your respective hospitals. Are you associated at all with the Port Hardy Hospital?
No, 2 years ago,
go in there.
I gave up my privileges, and for what I consider political reasons, I'm not allowed from stepping in the hospital.
But you can refer patients to the hospital?
Certainly, and I do orders to ambulatory daycare and infusions and various things. So it's almost a point of hilarity in terms of how badly I've been treated by Island Health.
Prean, is your ER open 24 hours, 7 days a week?
Yes.
Port Hardy Hospital?
We are not.
We are not.
Closed after 5 p.m., which we might get into this, but in my opinion, does not count as an emerge. An emergency by definition can occur at any time of day and requires emergency care any time of day.
Can't argue. An ER requires physicians, registered nurses, and access to on-call specialists.
We have that. We have enough
Port
physicians.
McNeil has enough but minimal,
So-
I think.
Yes. So the physicians, because of the 24-hour call, there's a lot of people trying to shy away from that, trying to work in sites where they don't require that, like we said.
Just because it's
Just
too
because
damn
it's too
hard.
much. It's too much. Why work
Too
for
much.
24 hours when you can work for 10 and get paid the same? So yeah, it's a lot volume-wise and effort-wise, etc. So as far as doctors, we could do it more. As far as nursing, there's union rules around that, but I think the nursings have been more robust in more recent times. But recruitment is an issue, which there are mitigation strategies to this, but maybe they don't have enough nurses available for different reasons. Not necessarily the lack of availability or lack of recruitment. In my opinion, there are other reasons why they don't. We don't have enough diagnostic staff. So you said
Okay,
doctors, nurses.
we're going there. We're going there.
Okay.
Okay. So supporting staff, lab techs, x-ray techs, respiratory therapist, negative on the respiratory. So if I'm having lung issues, I'll see a doctor in 2 hours,
Yes.
if I'm lucky.
Yes.
Okay. Clerical, admin, and security.
So one of the good things that have come out is the security for staff. So physical security, there's security on site, which has been a bit of a game changer. It has been very welcomed, very well received, and staff feel safer, which I think has been.
So has the need for security increased as the emergency patients come down from Port Hardy?
It's a 24-hour security coverage. I think they do 2 people per 12-hour shifts, and so it's steady. There's no increased security, for example, when the gates of hell open.
So you've got lab techs on call.
Yes.
You've got x-ray techs on call.
Yes.
Respiratory therapists, no. Okay. Do you have triage?
Yes and no. The nurses on the emerge nurses kind of triage. The people checking them in try, but it's not their role to triage. So do we have triage? Yes.
Sort of.
Soft yes.
Soft yes. Resuscitation and trauma room.
We do have one, but it depends on the staff available to be able to do this. The moment there is a code called or if there's some acuity, it depends on the threshold of whichever nurses are on and the doctors that are available. It's still the same one doctor, but do we have it? Yes.
And you only have one?
We have one trauma room, one resus room.
So only one can come in at a time?
One severely ill patient, yes.
The rest just have to wait?
They have
Because
stretchers
the rooms.
in the corridor or in the emerge or
So you have exam rooms?
exam beds,
Exam beds, okay. Exam curtains?
curtains.
Isolation room?
Yes, for the purposes, short answer, yes, because we have,
Okay.
through COVID, we had one, and then for mental health detentions, we have one.
Okay. Waiting room, you've got nursing station, access to the ambulance bay. Defibrillators?
Yes,
That had better be a yes. O2 supplies?
yes,
IV admin systems?
yes.
Point of care testing, for example, glucose and blood gases?
Yes, the point of care testing, however, has become a default for all the testing after hours. So there's the threshold to call lab in is very high. You have to have a very high threshold to call the lab in. So in other words, the point of care testing is in place of lab on call. The point of care testing is done by the nurses, and issues around that is like calibration. For example, we have a patient, we draw some labs through point of care testing. The labs are abnormal. Okay. So we have to be very careful about acting on those labs. For example, we had one with the potassium of it was hemolyzed, so it was 7, and there was a pH of 7.1. It was like, these are levels where we start instituting things like bicarb and significant more resus measures. The same patient, within the same time frame, maybe an hour later, suddenly the readings were normal. And so had we responded to this point of care testing, which we are dependent on using as diagnostic measures in the emergency room, that outcome would be not good. So suddenly we have to have a safety measure for the safety measure.
is somewhat unreliable depending,
Quite.
okay. So that's not good.
And that's a regression, right? We've gone backwards.
Yeah, yeah. Basic imaging, X-ray, on-call.
Threshold is high to call X-ray. If it doesn't change to acute management, we're not doing chest X-rays in the middle of the night if they have an infection or if they twist something or maybe break something, but it's not an open fracture, all that kind of stuff.
So if I come in and my arm is at some really bizarre angle, the
Call X-ray.
best, you would call X-ray for that.
But say because everybody hears a snap, crackle, and pop when they hurt something. So say it's your ankle, for example.
Yeah.
And say you went in a ditch and it was changed in some position, and you can't weight bear or anything, but it's closed. It's not particularly deformed. It's iffy but you got good supply, blood supply, that kind of thing. We're like, okay, you're gonna get a tensor, you're gonna get a wrap, you're gonna get some crutches, and you can get an X-ray the next day. The threshold to call them in is high because you don't want to burn them out because
You need them the next
we need them the
day.
next day.
Okay, and the mobile CT, how often do we have it up here? That's part of our big $30 million package.
It's fascinating how, and Dr. Armogam might have a different perspective on this, but to me, how opaque the availability of the mobile CT has been, because we have patients that, can't get to Campbell River. They can't get up at 5 a.m. to take the shuttle, or
It's
they
a real
can't
hardship.
drive. And so they want a CT to rule out cancer when it's in Port Hardy, when it's on the North Island. And yet we have no direction when we order CTs as to when it's going to be available. And even if it's something urgent and I call radiology on call in Campbell River, often they have no idea where the mobile CT scanner is. So, it takes some digging, figure out with the tech and otherwise. I've found I have to drive by the hospital, try not, get the security called on me and see is the mobile CT scanner there. So, it's bizarre.
How does that serve anybody?
The difficulty is that a lot of the exams cannot be contrast studies. So they're all non-contrast studies. A lot of the ones that have the most value are contrast CTs. So it depends on the tech or the availability of the tech and the fact that you can't do contrast CTs or that they don't do them at all. There's only a certain number of them that they can do. And access-wise, for example, having the CT scan also doesn't change the management. If you're seating acute abdomens, they generally need a CT, but they need a surgical opinion as well. So if there are findings on the CT scan, they still need to go to Campbell River.
Yeah.
Somebody, as an example, we had an intracranial bleed of an elderly man. The CT scan was available. The stars aligned on that particular day. He got a CT scan to show that there was, in fact, an intracranial bleed. But the transport pieces said he can only go the next day. This is a well man. He's got no medical history. He's not on blood thinners, etc.
So we're just going to let him bleed into his brain until the next day.
So you ask yourself, what is the value of having something that's of little value to patient management, patient care, patient access to care? What is it, a token type thing? And why are we doing this if we can't do it properly?
Again, this, arose with all our Emerg closures, and in fall 2022, I was fairly recent to the North Island. I'd worked with physician assistants and felt that was a way, as we were losing our doctors at that time, to keep
You
the
advocated
Emerg
really
open.
hard for that.
Exactly, to keep our Emerg open as I'd experienced working in rural Manitoba. And so, we created Buzz, North Island Matters, and the various advocacy arms and the rallies in Port McNeill generated buzz so that then Minister Dix, Minister of Health, made a big announcement on behalf of the Ministry of Health of $30 million, a mobile CT scanner. They put up the signs. That was going to save health on the North Island, right? And again, the question is, as Dr. Armogam had presented, does it change management? Was it asked for? My partner's a commercial pilot, and she and I were here the day Minister Dix made that announcement, and she remarked to me, it sounds like an airliner buying planes without the pilots, right?
Exactly.
So what's the point? How's it going to change management? If you don't have the staff, if you don't have the person to give the contrast, to manage the issues, to do the studies that you need, is it really just a political gesture?
And if you do get the CT and discover that intracranial bleed, if you don't have the systems in place to do anything about it after that, so like you're still stuck. You're still stuck. So given this list of requirements to qualify as an ER, would you say that either of our hospitals fit the definition of an emergency room?
I think it does not fully meet the definition of an emergency room, but I want to say there's a lot of chatter in the national physician voice. There are Society of Rural Practitioners, for example. There are other folks who've been around for a long time and seeing closures not just across BC, but across the country to some extent. And some of the thinking and some of the thoughts go back to really the Canada Health Act. So the Canada Health Act says, equal care for everybody all the time, that kind of stuff. But it's impractical, particularly in a rural environment. So either the Canada Health Act needs to be reviewed or upheld, right? If we want emergency room level on a lot of the areas that we're going to. So you talked about urgent care centers, and now it seems to be by default. This is what we've made the emergency rooms in the region. We've made them emergent care centers. We've not the semblance of an emergency room, but they're not actually emergency rooms. And now there's only one emergency room, which cannot actually filter a lot of patients. We lack the ability to actually provide definitive care to people. Ultimately, most people are going to a higher level of care if there's any acuity attached to them. So the chatter around the national level is there could be good care. There could be good care in an urgent care setting, but there needs to be predictable access to care in an emergency room setting. So, for example, in our locality, in our region, if Port Hardy is closed, it does function as an urgent care center at the moment, like Port Alice, like Alert Bay. Port McNeill, meant to function as an emergency room as well, but also not able to meet some of the criteria for it, and so they're doing it. So why are we not intentionally diverting resources, repurposing resources to a place that's predictable, that's fully accessible, that we can actually deal meaningfully with some kind of presentations, and absolutely send it to a higher level of care if we need to, but why not we have this on a somewhat predictable basis? So as far as the closures go as well, there's also the whole idea of predictably announcing to the public that it's going to close at 5 o'clock or whatever it is over the last few years, is that it's going to be predictable. At least people know. We know we have not enough physicians, not enough lab staff, not enough nurses, but at least people know. But despite that, we still have closures without knowing. So senior folks like managers, directors, etc., not long ago, about a month ago, we had a 3-day closure because of the absence of any x-ray in Port Hardy. So not only were they not open in the nighttime, but they were also not open in the daytime. A call made by somebody, but the directors were unaware, shouldn't have happened, but yet it happened.
Yeah.
So suddenly Port McNeill, without they're still catching the mother lode, the gates of hell at 5 o'clock, had to also cover the region in the day hours. So obviously that physician, that staff on that day, but not predictable. So if we're spending all of this stuff to keep emergency room opens, we can't meet the definition of an emergency room. What are we doing? What is it we're doing? Why is the public, why are we as people using the service or as people providing the service accepting that this is the status quo?
As general public, I'm told we have an ER. I would expect that level of care in an ER. And it's deeply disturbing to discover that, well, no, we're really kind of not quite an ER, but we're like an urgent care center. Like, people need to know that.
I've always been about advocacy for patients and providers. I think patients needs to know that coming to the emergency room doesn't get you a mental health, attendance. Or if you're a frail person, if you have an elderly family member, you're not getting. If there's an acute problem, they may be able to fix it, but there's nothing else that you'll be able to get in an emergency room. The bed pressure in Port McNeill alone, it continues to function as a long-term care ward because a lot of folks are waiting to go somewhere else. We don't keep acute people, so it's basically a revolving door. We generally send you out somewhere. Or there's this gray disposition area, we don't know what to do with you because you don't have an acute problem and you don't have a problem we can fix, but you can't go home, don't know what to do. The system is not designed, so yet everything defaults to this one place. So the other services around this acute care provision is not there, including sort of clinic care to mitigate that, including community services to mitigate presentations to the emergency room. Now, don't get me wrong, if people are having an acute problem or something that they need urgent attention for, they should get it in an accessible, predictable way to a place that is equipped to deal with this. Not because, oh, it's default, there's nowhere else to go. A lot of the community services say, well, people should just go to the Emerg. People need to understand what going to the Emerg actually means, because there's not a lot that gets done in the
It doesn't
emergency room.
mean what it used to mean
It
or
does
what
not
people
mean,
think
correct,
it means.
Correct, it does not.
And it also opens up the space where, as we do here at the North Island Community Health Center, you can take some of the burden off Emerg, right? We offer Monday to Thursday and Saturdays a walk-in clinic, and we get consistently 10 to 15 plus patients who otherwise would be going to Emerg. And, you know, as physicians, we're highly trained professionals who take responsibility, and that is valuable. That means we're able to separate what could be versus what is, and actually do a great service to the patient and to the medical system by taking that responsibility, making sure it's not a heart attack, making sure we're managing what could be a sprained ankle versus a broken ankle, and then working, you know, in that context. And so, you know, I think we need to empower and strengthen our primary care system, because that will strengthen our emerges.
Which hospital has the larger emergency room area?
Port Hardy.
Port Hardy has more beds for Emerg.
Yes, always has.
Okay.
And I think, you know, it's important too that we don't lose sight of the fact that, you know, in parallel, there's been active recruitment of physicians here to Port Hardy. Now where we have 4 physicians here at the North Island Community Health Center, 4 physicians at the Island Health Clinic. So we've got 8 physicians, family doctors, and, you know, many of those have privileges with Island Health. We have a huge capacity compared to when I came here in Port Hardy in fall 2022, when I first set up my family practice. We had, you know, several doctors that were leaving. We had, you know, one doctor who's exclusively doing Emerg, myself doing some Emerg, and then locums, right? So we were down to 2, maybe 3 doctors. Now we have 8 doctors, right? We have huge capacity here in Port Hardy, and the hardest individual to recruit in the healthcare system is the doctor. So we can't accept these excuses that are coming from the health authority or the Ministry of Health that it takes time. It's been 31 months that our Emerg has been permanently closed, and we don't have a path to reopen it. So that's, in my perspective, where I'm advocating for my 1,800 rostered patients and the 5,000 patients that are part of our community health center. That's my reason for being, and that's why I'm here today. Is, my little piece of advocacy is saying we got to reopen Port Hardy Emerg.
The thing that puzzles me, in the short time that you've been here and you've opened this center, you've got now 4 physicians here. Why can't Island Health attract physicians?
Well, they have that's why we have enough physicians now. Granted, they're return of service physicians. So
they're not necessarily here because they want to live here and make this their home.
No, they're almost exclusively not. Right? They're exclusively voluntold to be here.
Voluntold.
And so they put in their time, and that's been the revolving door of return of service physicians. And, here in Port Hardy, we had Dr. Lee, who's through and through. He talks about it being chapters of his career, where it's a different return of service doctor, right? And that was my commitment. I moved to Port Hardy, August 2022. I bought a plot of land. I built a house. I built this community health center, spending over $250,000 of debt. It's not money I have, it's debt, to create a new way of delivering health care, because I knew we had to assure the population that I'm not going anywhere.
Well, and that's just it. They're so used to locums. Like, where is this sense of family doctor, a doctor who knows me? I can come in and say, oh, Prean, my shoulder's bugging me again, and he knows exactly what's going on. Like, that concept is becoming a distant memory.
And that's valuable. Again, we don't put a price on that. We don't give a value to it. But the amount of money that you've spent and we've spent on the healthcare system, where people come in, they see a doctor once, and the next time they come in, it's a different doctor because the doctor's left. How much does that cost the healthcare system in unnecessary visits?
I want to step in about the advocacy piece and sort of health authority clinics and non-health authority clinics. Between Alex's clinic and our private clinic, which shouldn't really be such a big distinction as regard health authority versus non-health authority clinics, the supports for health authority clinics are phenomenal supports. Not only so the mandated return of service, the voluntold, some stay a little bit beyond, it's the overhead, it's the cost, it's the support. The bulk of the patients in this region are actually covered through Alex's clinic and my clinic. Small clinics, private clinic, non-health authority clinic, but we can ask, you can, with no support.
Zero support. I mean, when did Dr. Armogam last have a locum or time off, right? He deserves that. He deserves that.
When was the last time you went away on a holiday?
4 years ago.
4 years ago.
Yeah. But the point
You
is,
have a holiday.
I'm a bit luckier. I don't have the commitments with the health authority, so that changes things a little bit, right?
Doing the outreach
Totally.
stuff is...
So the support, the inequity in the support regarding the primary care, the provision of primary care in the clinics, in the community, health authority clinics versus non-health authority clinics. This some doctors on call can get paid one amount of money and another group of doctors.
And the same with the nurses.
And the same with the nurses, yeah. You're an agency or you're that kind of stuff, or part of the casual, or there's so much inequity in how it's administered. But there's always responses about it's so hard to recruit. This time it's lab staff, and this time it's X-ray staff and nursing staff and doctors. This whack-a-mole type activity, and there's no participation points in this thing. Participation points does not alter patient care and patient safety. Participation points and well-intentions do not translate to outcome measures, do not translate to what care looks like on the ground. Speak to the frontline staff, listen to frontline staff, take direction from frontline staff.
But frontline staff aren't allowed to talk about it.
And so that's the first thing that should change. There should be an open invite. There should be an open invite from the Minister of Health to encourage this kind of information, so that real information can actually distill up to the powers that be that make decisions. We've talked about ineptitude and indifference, whether they can do it or whether they just don't care. It's immaterial. The point is that people are dying. There's huge patient safety issues, and there's physician safety issues. The psychological safety and professional safety of people functioning in a tired environment, in an unsupported environment, in a non-unionized environment. Physicians are left with all of that to deal with, whereas other folks, administrative folks, other people who are unionized, and thankfully they are, but we are not supported in the sense that we're able to provide good care. So all of the physicians in the region, now some of them are leaders within the, it's often taught that they were sort of cheerleading a decision that was ultimately made by Health Authority, which is an agency of the ministry. But the net effect is that patients are still needing things. People are still dying and going without, where there's still huge access issues to care in a primary setting, in the emergency setting. There's still huge transport issues. And everybody's, we're continuing to engage and be busy. Participation points does not save lives. Participation points does not alter patient safety and patient outcomes.
And you're exactly right that you have to empower the front lines to speak. Since when did signing on as a healthcare professional mean you lose your freedom of speech? Somehow it's been decided that we lose our freedom of speech. And, Dr. Armogam and I are taking a stand today, being here.
You're putting yourselves out there.
We're putting ourselves out there, and we're taking a risk. We are taking a risk. There's, a relatively new Health Professions and Occupations Act, HPOA, that came out of Bill C-36, which means that we're vulnerable as professionals, even as, highly trained medical doctors. Advocating can get us in trouble. It can get us fined. It can get us losing our license potentially. That's our ability. That's my ability to feed my daughter.
If the physicians can't advocate for us, who's going to?
Patients need to advocate for themselves with information provided to them. It goes back to this disclosure and the need for public to know what safety things that they're facing. None of this we're doing our best. None of this we're making efforts. Participation points does not.
And it comes back to the impact again. This impact is all on the front lines. And then it maybe goes to some report by the time it gets down to Victoria, where there's no impact.
I just come back to my patients, the patients I see every day when, like Dr. Armogam, I'm seeing 40, 50, 60 patients a day. It's busy. You're getting lots of stories, you're hearing lots of tragedies, and these patients are suffering and they're struggling, and our lack of Emerg in Port Hardy Emerg, a lack of an open emergency here in Port Hardy, is contributing to significant trauma, significant morbidity and mortality. And it's an untold, unnecessary story when we have enough physicians. And I won't tolerate it. I'm not going to go away quietly. I'm going to keep hammering this. It's been 31 months. Fortunately, we've had a change. And that change that is promising is something that me as a nonpartisan, I voted for every one of the major parties, but I see a change where we now have a member of parliament and a member of the Legislative Assembly that are willing to stand up and speak out for our patients and for our providers.
I've spoken with Anna Kindy, and her commitment is very obvious. And I feel like she's little bitty, but I'm hoping she's going to poke some big bears and make some changes. Bottom line, who made the decision to close the Port Hardy ER?
And keep it closed.
And maintain, keep that closed. For a savings of between $300,000 and $800,000 a year, they're putting our lives on the line for that amount of money per year. Who figured that was the best
Let's
deal?
remember this population that's contributing to the gates of hell opening at 5 p.m. in Port McNeill. This is 3 First Nations reserves, a 4th First Nations off-reserve population in Port Hardy, and then, a blue-collar population that has tremendous morbidity and, tremendous illness within it. It's tough population. This isn't Kitsilano.
And I wanted to mention too, when you were talking about seeing up to 60 patients a day, as a patient, I don't feel like I'm getting the time with my physician to talk about stuff. Like it's, okay, you have this appointment, you're going to go in, we're going to deal with this, this, and this, and away you go. Because you just don't have time anymore to do that.
Yeah, I'd argue it's the art of medicine. So, as physicians, we can spend 30 minutes with a patient and they can feel rushed. As physicians, we can also spend 8 minutes with a patient and they can feel like they were the center of your attention and nothing else mattered. And that's, as physicians, our responsibility. And I've got colleagues here at the North Island Community Health Center that'll see a third as many patients in a day as I see. I've got significant expenses in running this health center, so I've got pressures to see patients. But I also enjoy moving quickly. And I find I'm a better doctor because I see more patients. But that's my style.
I think for me, a lot of times that I go in, 8 minutes is fine. Yeah, I just need this. Yep, here you go. Okay, done. Happy with that.
So it comes down to a few things, so health literacy for a lot of people is variable. Each of us have a different understanding of where that is, but I agree to some extent. It's the art of medicine and how you deal with your patient population that gets to come and see you. But also I want to touch on a little bit more. And more recently, we're again the frontline first people that patients come to. My CT scan that I ordered 3 weeks ago is not done yet. My MRI is still several months ago. The specialist that you sent me to in April, I haven't seen them, and I've still got blood in my urine, kind of thing. Mm-hmm. But we're responsible. We're the recipients of the patient and the public angst around what that looks like. So again, a symptom of a failing healthcare system. But I think patients and the public are unaware that it's not really up to your primary care provider to be responsible for those decisions. And I think people need to mobilize a collective voice if they want to, firstly, to understand that it's not the primary care providers that are doing or not doing, and what other response there needs to be at a different systems level. So for folks to understand that it's making a fuss at a level that matters, because your specialist appointment and then coming in with a list or not. So if you see a family doctor often enough, they get to know you, and this concept of longitudinal care and knowing about whatever you're presenting with, and knowing your family doctor and them knowing you, more importantly, in your chart. folks also come with like a list of things, and some people love the fact that this is an outing for them and they want to come and share. Not many, but some people do. Some people do. But for the most part, people come and say, I've got this, and this is what I got. Check it out, and this is what you advise, and off they go. So we have to scalify it, but I would default to that. It's still the art of medicine, about different people presenting with different things, and people's understanding and literacy of medicine and their own body is a little bit different. So, but that's the challenge. That's the art. That's what we do every day, all of us.
We need to recognize that matters. The art of the physician matters, and physicians need to lead our healthcare systems. The solutions are there, and we're the most cost-effective means of delivering healthcare reform. It's not bureaucrats, it's not the politicians, it's not the people sitting in Victoria. Listen to doctors. We will deliver the change that we need. And you just look at what we've created here in the North Island Community Health Centre in over 2 years, and we've managed to transform the primary care system in Port Hardy, and I would argue Northern Vancouver Island. And we've done it, with minimal input, actually no money from the government, other than my private billings. And so, what can we do? We had the rural health critic and rural seniors critic, Brennan Day, MLA from Down Island, come into our health center here, and he proposed various options. We discussed that, right? We need to get the politicians providing solutions, consulting with physicians. One of my roles is on the board of directors for BC Family Doctors, and I look forward to meeting and engaging with the Minister of Health on these solutions.
Many years ago as a teacher, I kind of felt totally unempowered. I felt powerless in my job. And I was speaking to someone and I said, yeah, I just feel like I'm the bottom of the totem pole all the time. All this direction comes from the top down, and they have no clue what's happening on the front line. And that person totally turned it around by saying, the base of that totem pole is the foundation.
Totally.
You are the base. You are the strength. And that needs to flow up, not down. And I think the same applies here. It is time for politicians to get the hell out of the way and listen to physicians, because you know what our community needs. Physicians at Central Saanich know what their community needs.
And we're guided by our patients. That's the primacy. We are accountable to our patients like no one else. Politicians are accountable to their voters 1 year, or 1 day, maybe in 4 years. We are accountable every day to our patients.
It's exactly that whole reverse inverse care thing. And so for me, I think this placating piecemeal thing, you cannot fix pieces of it or seemingly fix and placate pieces of the community without fixing the whole thing. And so, but the dividing and conquer approach appears to have worked, because we cannot collectively stand up and say the whole region is broken and we need to fix the whole region. By getting a little bit of something here and a little bit of something there does not quell the urgency. We still need to have that.
It's Band-Aids.
Right? It's Band-Aids.
It's Band-Aids. And the healthcare system needs significantly more than Band-Aids.
Yeah. I want two things. I hope for two things in our region for us to effect change. One is an actual invite from the ministry around advocacy from frontline staff, whether those are physicians, whether those are nurses, and to be able to speak freely in a safe space and an environment there's no retribution to doing that. The second thing I want is an accounting. There is no, you talked about the cost of certain things in an ordinary business. We're still having a public purse that is an infinite amount of money, and when that runs dry, our premier goes to the federal government and says, please sir, can I have some more? But how about managing what we have? Because there's no infinite amount here. So there's no justification on the 30 million. There's no breakdown of that on what it actually, how did we measure the value of that spending? What did we do to it? What did we do with it? Overall, how is the cost actually spent? There's layers and layers of management and directors and decision makers, but the people doing are not actually getting what they need to do. They don't only get a voice, there's not enough people who are doing. And sadly, some of the physician groups and people who become regulators, administrators, they forget that it's all about patient care and it's the frontline delivery of patient care. That's what I feel needs to happen. And I think that echoes a sentiment from a lot of physicians who feel this sense of frustration, gagged on one level, but at the same time unable to effect change at another level.
And if you want to know why we've been able to attract new physicians here at the North Island Community Health Centre, is they recognize we're doing something different. We're empowering physicians and our allied health providers to be open with sharing what they believe and sharing what they think and advocating for better. You can't advocate for better if you're stuck under the finger of a bureaucrat.
You can't, because they're all about the business. And it's not about the business, it's about the people. And they've forgotten that.
Cheerleading and about the business rather than the patient.
Absolutely.
No participation points and good intention just does not get you good patient care or safety.
I want to thank you both for your time. And I especially want to thank you both for caring. I very much feel the passion that you have in advocating for your patients. And I wish it were possible for more physicians to be able to step out and do the same. Thank you so much for watching. As always, I hope you learned something. Thanks. I've just had a conversation with 2 North Island physicians, and they've revealed to us some very real and very scary information. Island Health, I invite you to step out of your offices and come sit with me at the table. I'm offering you a chance to take accountability, to take responsibility, and explain why people on the North Island are dying because of decisions that you have made. Come sit with me. We'll talk.